morning, everybody around the world. My name is Hélio da Costa. I'm an orthopedic and trauma surgeon here in Brazil, Brasilia, capital city. And I'll talk about surgical hip dislocation in traumatic hip injuries, a case-based approach. I have no conflict of interest to declare, and this is my affiliation: Brazilian Hip Society, Brazilian Orthopedic Surgery, All Trauma, AAOS, and ORC. Okay, this is the case of 15-year-old male, previous history of slipped capital femoral epiphysis in 2015 in situ pinning in the left hip. He was referred to trauma center after a motor vehicle crash. He was on a motorbike on the day before, and after he went to a minor trauma center, and after clearance of trauma team, directed to the ortho trauma department. And his main complaint was pain in left leg and fixed internal rotation and flexion deformity. After X-rays, we saw this complex and awkward case, one slipped capital fixation in situ and a minor PIPQ1 fracture, but with the instability on the left hip. After 2 attempts of close reduction, we decided to open it, and we can see one crossroad here. I was between a single incision, a less complex incision, and only solving the problem, or I would try to do something better for the patient and try to restore some function for him. And he said, okay, let's try to do it. And we opted to a surgical hip dislocation, which in some complex cases allows for 360 degrees visualization of femoral head and the acetabular surface, allowing to bone and chondral repair often, and also for correction of the biomechanics and anatomy of the proximal femur. Due to this complex deformity of the proximal femoral end, we tried to do a relative neck lengthening plus osteochondroplasty of the femoral neck, head-neck junction, to try to restore function and anatomy of this joint. And as a young guy, we should try to do something better for him regarding concerns about degenerative disease of the joint. So, okay, this is the post-op X-ray. We can see here some better function and a better anatomy after the surgical hip dislocation. We slided the trochanteric flip distal and distally and anteriorly, so we gained some lever arm for the abductor muscles. I'm having some trouble here. And our follow-up was from week 1 to week 4, passive range of motion, isometric exercises, and no weight bearing. After between 4 and 8 weeks, active movements, partial weight bearing, and after 8 weeks and radiographic control, full weight bearing, resisted strength exercises, and we used VTE prophylaxis, aspirin 100 milligrams, 2,000 a day, 4 weeks. I don't know if this is the video of our patient in the 5th week postoperative, allowing good function and good range of movement. He couldn't abduct his hip yet, but he was satisfied with this this result at 5-week post-op. So The evidences about surgical hip dislocation and trauma, we have some authors who performed case series analysis, and most part of them can tell us that it's a reliable and safe option for treating this complex trauma, major traumas, minor risks of osteonecrosis of the femoral head, lower complication rates, and good function in the follow-up. Still, though, we don't have any clinical trials regarding this surgical approach to the hip, and it doesn't allow us to have strong evidences about superiority regarding short or long-term follow-up. About relative neck lengthening, we have some evidence. Again, no no strong evidence, but in some key series, we can see a good range of motion after the minor numbers of osteonecrosis of the femoral head, and good clinical and radiographic follow-up results. In one study, a very recent study, Bristol in the Hip International mentioned that some patients exclusively treated with the relative neck lengthening doesn't go so well. So sometimes they need some PAO or some additional procedure. But even though we have a good increase in function and range of motion. So some technical tips are required to perform this approach, and ideally some interval muscles must be preserved, as Gavaskar and associates told us in last year. The thickness of the trochanteric flip is a very specific point. We don't have we have to be careful, because if it's too thin, it will break during manipulation, or maybe in the time of fixation. And we have to be more careful about capsular dissection to not injury the labrum or the chondral surface of femoral head. And to prevent complications regarding trochanteric flip fixation, it has to be some stable fixation in order to prevent these trochanteric non-unions and preserve abductor function. So about pros and cons, we have a surgical hip dislocation as a safe approach regarding vascular supply to the femoral head, 360 degrees exposure for femoral head and acetabulum, which provides good options for the surgeon to solve problems, even though it's trauma or preservative surgery. Removal of fragments and fixations is easily performed, and in this specific case, only through this approach we can have anatomical and functional correction of the abductor arm and hip biomechanics. For concerns regarding this kind of surgery, it's an extended surgical time. We have a steep learning curve and some extensive blood loss, which can be weighted regarding trauma patients. And we also have concerns regarding trochanteric flip and orthotopic ossification. One question which is not answered yet is if this kind of approach and this kind of procedure will prevent OA progression, and it's also a point of interest in future research. And this is it. I have. It's been a pleasure to participate in this conference, and many thanks to everyone in the organizing committee.